Hey, cheeky chatters. We are here for another Tuesday live. And this week we're going to be talking about endometriosis because March is Endometriosis Awareness Month. So this whole week, today's about teaching. Tomorrow we'll post about different complementary therapies that can help with pain management with endometriosis as well as surgeons. So if you have endo and you have recommendations for these complementary therapies or even surgeons, please comment on the post tomorrow. And at the end of the week, we're going to be creating a little endo support group online. So it'll just be within this group. You know how you can create a little private message where you can chat with people who are within the group. So we'll be creating that, and if you're interested in joining a little group, you can. I actually don't know how to do that, but I'll make one, and anyone can join it who has endo. Anyway, so I have been seeing a lot of women post about endo on different Facebook groups recently. So I'm really happy to start talking about it here in Cheeky Chats. And first, I just want to talk about two big stats that I have been coming across that I want to share with you guys. So the first one is that this is crazy actually, that it can take 6 to 12 years of consultations for somebody with endo to even get a diagnosis or to get any answers. Luckily, I hope this is starting to change just with more and more people, and by people, I mean physicians and doctors, learning about it and being aware of it. But it also can take 5 or more doctors to get that diagnosis. So it's really, really important to advocate for yourself if you suspect that you might have endometriosis. And in tomorrow's post for different doctors in the area, whether it's in Wilmington or Chapel Hill, any endo-friendly docs, please share them with the group below. The other stat I wanted to share is that over 50% of people with endo struggle with infertility. And so we have another guide that we'll get to that talks about infertility later, but I did want to pull that in. And with endo, I find that there are a lot of misconceptions and myths surrounding that diagnosis. And the biggest one is that previously, and you'll see this in a lot of places still when you Google endometriosis, but originally it was thought that endo is endometrium tissue, so tissue that grows in the lining of the uterus is growing outside of the uterus. But after more testing and study of the tissue, it has been found that the lesions are actually different. And the properties are different than the actual endometrium lining of the uterus. So while it might seem similar, it's actually different abnormal tissue. And the tissue, another myth is that the tissue or the endo is a reproductive or a gyne kind of condition. But we know now that endo can grow anywhere else. So a lot of times people will find it on the bowel, on the bladder, diaphragm. So really it's a systemic condition, and it affects can affect your digestion, respiratory, urinary, reproductive, your immune system, your lymphatic system, your cardiovascular, your nervous system, and your musculoskeletal system. All that to say that it presents differently in people. So even though one person might experience these kind of symptoms, another person with endo will experience these symptoms. And so that is also why I think it makes it so hard for people to get a diagnosis. So yeah, that's just a little bit about what it actually is and how it might present in the body. One big thing is, you'll hear, I don't know if growing up, in school, maybe middle school, probably high school, there would be some friends in my classes who would have to call out and not be at school because of the pain from their periods. And while having cramping and some PMS symptoms might be like normal-ish, having it to the point where it affects your quality of life and you aren't able to function that's not normal. That would be abnormal. And I think back to all those times and now knowing that that could be a really early sign of potential endometriosis, I think could change so much for young women in middle school and high school. So that's something that I think is changing and getting a lot better. And then we'll get into different interventions in a second. Okay, so different symptoms. So we talked about the different, like what endo is. We've talked about what systems it can affect. Now we're going to talk about the different symptoms that you might actually have. One is very painful periods. That's a big one. 2 could be painful sex, pain with intercourse. 3 could be painful, difficult bowel movements or like bloating, chronic like abdominal or like pelvic pain. That's what we'll see a lot of in pelvic PT. Back pain, hip pain, nausea, vomiting, constipation, even diarrhea. So sometimes people might get diagnosed with like IBS or even IC, interstitial cystitis, which is inflammation of the bladder. Also food issues and brain fog, fatigue, sciatica would be like a musculoskeletal sort of symptom. Trouble breathing if it's affecting your lungs or your diaphragm. So it just goes on and on and on. But as you can see, the common denominator is that there almost like isn't one, in that it can affect a lot of different symptoms, and your symptoms might look very different than somebody next to you who also has endo. So that was a little bit about symptoms. Now we're going to dive into some diagnostics. So let me actually pull it up. I wonder if I can screen share on this actually. Let's see. Let's see. Okay, I think I can. Sorry. Learning new things. So NICE, I don't know if I say NICE, but it stands for National Institute of Health and Care Excellence, but I just say NICE. They just released a new guideline in 2024 for diagnosis and I think it's just diagnosis for endo. So I wanted to share that here. If I can't screen share, then I'll just post it below. Yeah, I don't know, maybe I can't share. Sorry. Yeah. Anyway, I'll just talk through it. So for the NICE guidelines, what was changed, so I'll just talk about what was different, and then you guys can look at the actual thing if you want. But some new considerations when it comes to endo diagnosis is a family history of endo and acknowledging that people express pain in different ways. So that's the biggest consideration that's added. In terms of diagnosis, previously there were, and maybe probably still now, there's a lot of like pelvic MRIs and looking at the marker for cancer CA125. Those were things that were used to try to diagnose endo, but now it's recommended to not do that. And really the best way to diagnose it is through a lap. So for them to actually go in and excise the tissue and then study it to confirm that it's endo. Because sometimes endo doesn't show up on a pelvic MRI, sometimes it doesn't show up on an ultrasound, and someone has to be a specialist to be able to really like identify it. So the guidelines even say that if there is a negative result on one of those diagnostic tools, that should not by itself like rule out the diagnosis of endometriosis. Because I think a lot of people get discouraged when it comes back negative, but that might not be true. So, okay, what else is different? Another thing that's different is a lot of the kind of what do you say, action items would say, oh, consider referring to XYZ. Now it says refer to. So I think that's a very clear indicator for people who are diagnosing this to know that not consider it, like do it, like send that referral. So yeah, that's some of the big things. One last thing is another factor that was added into the things to look out for is the daily life impact. And I feel like that's important to talk about because the daily impact is how someone's quality of life, and just assuming that because somebody, you know, I think I haven't had this experience personally, but I have just last week. I was talking to a woman who is in her 70s or like late 70s, early 80s, and she was saying when she was 18, she was experiencing really, really bad period pain. And her doctor told her that it was psychological. It was all in her head. And I think that is kind of like obviously wrong, and gaslighting. But, just to consider for healthcare providers to look at the whole picture of the person and not just the imaging. Okay, so those are the guidelines in terms of diagnosis. And even, this is another thing I saw a stat, is that for situations where endo is affecting the bowel, people will start to have bowel symptoms, and so then obviously you get a colonoscopy if you're having bowel symptoms. But in 92% of cases of bowel involvement, those cases failed to diagnose endometriosis because a colonoscopy is looking inside the colon versus the endo is growing outside the colon. So in terms of interventions now, the gold standard of an intervention is excision. And excision is different from an ablation because excision excises the endometriosis versus an ablation just superficially is like burning it off. But the results have like poor outcomes and a lot higher like reoperation rates than excision. So unfortunately, ablation is the most common surgical approach for endo, but really it should be excision. Sometimes people will get a hysterectomy to get rid of the endo, but if you think about it, endo can grow anywhere, so getting the hysterectomy doesn't really solve the problem. On the other hand, there's adenomyosis, which is when it's growing, when it's actually like growing in the like muscle tissue of the uterine wall, and so a hysterectomy would help for that, but not as much for endo. And then I've also heard doctors saying that getting pregnant could also fix endo, but there were studies that have been done now that show that even during pregnancy and even taking birth control does not actually get rid of endo, it just masks it. So it's just a band-aid for the problem, because endo can continue to progress while you're on birth control and while you're pregnant. We talked about the gold standard being excision, but even with excision, some patients might need to have multiple surgeries of excision, and so yeah, just FYI. And for some patients, sometimes the excision totally like takes away their pain, but for others it doesn't. And so the reason why that is because frequently These patients might suffer from other things because, like, for one, pelvic floor dysfunction. So that's like what we treat is the muscle. So after years and years of like chronic pelvic pain from endo, your pelvic floor just gets so tight. And when that happens, we have to go in and manually treat the pelvic floor. So that's the musculoskeletal side of it. And then you have the nervous system side. So when you've been in chronic pain for years, your nervous system has changed, and that has to also be addressed. So that's just a little FYI. And then in terms of complementary pain management kind of approaches, like one, pelvic floor physical therapy, of course, but also like nutrition, nerve blocks, dietary changes, any kind of like pain management, even like mental health therapy, not because it's in your head, but because it just impacts your life so much, that's really important too. So yeah, those are some of the complementary. Maybe like acupuncture too. I'll provide a full list tomorrow and post it. I just can't think of everything right now. Yeah, I did not get any specific questions about endo, so if you think of any, you are welcome to comment it below this video, and I'll just type out a response to you. So I hope that this helps at least get rid of some myths that are out there about endo, as well as clarify some of the like diagnoses. I don't know if that's the right wording, and also the interventions. But happy to help and here as a resource.